we've called NHS Direct, but
we should be writing something to identify.
There are papers with the name NHS Direct,
Right, okay.
which is this project.
So you might want to write down
Yeah,
this
I
is
was
about
gonna say,
this is
I
about
have to
this
write that
one.
down anyway.
Have you got a horse?
Could get confusing.
We'd love you to time it. Okay.
Moving sailor time.
Great.
Our challenge was, what should the next generation of NHS Direct be? I think we have to confess, we were inspired a little bit by Gordon's conversation with us this morning about highlighting the impact of the growing demand on the A&E attendance. And we were also inspired in our solution by some of the research we did that was saying that the current generation of NHS Direct, the phone app of it tends to be used by people more if they are looking to avoid A&E, and the web version much less. That the web version tends to be used if people are avoiding GPs. Our assumptions are that if we need to change the way that the NHS is interacting with patients, and if we're going to maximise the resources we've got, then we need to try and find a way to make the web access more authoritative and more reassuring, so that we can get more people using the web access rather than going to A&E. So that was our objective. What we've come down to as our solution is what we're starting to call our talking head. We have got a bit of an acronym, but we're still playing with that. But it's based on the concept that instead of doing a web-based questionnaire, which is very depersonalised and not very reassuring, that we want to move with something which is more around video consultations. We think they'll be pre-recorded, but we think that there is technology that will enable us to be able to make sure that they are both interactive and responsive, so that somebody feels as though they are actually being listened to rather than just having to fill the form. We started off by looking at the range of different channels, but we're listening to advice and we're starting to think about we may need to start it on just one of those channels to start with. There may, though, we think, be opportunities later to expand that into alternative channels as well. But that's why we like this idea. It has the opportunity to start small and to grow. The key bit for us is that bit about the human face. And when we looked at our people that we thought we needed to influence, one of the key things that was coming through was that sense of people needing reassurance and the need to actually have something that feels that you're being listened to, that people understand your anxieties. And so what we'll be looking for is something that enables us to give somebody with authority. It's that bit about, I need to see a consultant. Actually, we can't give everybody a consultant, but if we can find a technology that means that they've got that access, then that may help. We think if we can do it in this way, we can actually have different responses, so that we can ask some demographic questions. That means that we can get the right person to talk to the people that are on the end of the web. And we think that by using some of the technologies that Pete has been using, there may also be the opportunity to embed some case stories or some information videos within that as well. And we think there's the opportunity to ensure that there are questions around some of the emotional and psychological issues of somebody who is anxious and thinks of an emergency and might end up in A&E, so that we can ask some questions around mood or pain measures. There can be a way to reflect on that, and there can be a way of ensuring that people get some recognition that there's something more than just physical symptoms, get some reassurance on that, and also to help with some of the algorithms and the clinical decision-making tree about what the follow-up should be. Because the other key bit that we think still needs to be in this bit, we were given some feedback, but we think there has to be something which offers a feedback, automated, but tailored to the symptoms and to the answers that people are giving. So that there may be either a text or an email that says, based on what your symptoms are, we're going to follow you up in 6 hours, 12 hours, 24 hours, 2 weeks, so that you're not just left and it's not a one-off interaction. I was very inspired by having listened to some of the clinicians in York talking about one of the difficulties with A&E is they don't have the option GPs do, which is go away, come back in 2 weeks if it hasn't cleared up. We need something that offers some of that flexibility, we think. So there may also, we think, need to be something that says, in that period before we follow up, what are the things you need to monitor so that you can tell us whether you think things have improved. We think there is additional options as well that can be added onto that. I'm not going to go into that at the moment, but we think there are some additional things that can be developed developed around that feedback loop. If it works on a simple basis, then we can build more into that feedback loop. We think there is the opportunity also to develop how it enables people access to some of the self-management tools, so that on an ongoing basis they can build up that picture of what's happening in their condition and understand what's going on, whether their symptoms are improving over time. That's broadly our initial pitch. Have I missed anything?
2 seconds to spare.
Our idea, we've entitled Health Spark. The idea is going to be our health conversation space. We're looking at bringing together all the social media channels discussing health into a single place. So a place for health conversation and community action. I'll come into why we say community action in a second, but it is a one-stop shop for the conversation on health in York, and it can be developed further to cater for national and further down the field. One of the main key benefits is going to break down the barriers between people, healthcare workers, people in the health industry, and join those conversations together about specific topics. So there's going to be two elements to it. First, and to use the term that we've been trying to avoid, is going to aggregate social media data. We're going to bring it all together into a single location, identify trending topics, allow people to rate conversations and identify the important piece of information that are being discussed at a time. As well as that, we will use this as a tool to then provide a facility for healthcare departments, public sector, to raise topics within the social media space related to healthcare, track those conversations in order to devise actions or further decisions to be made on what happens based upon the community opinion, whether that's decided on then or based upon the community opinion, or it's just used for research. So we've got various other facets to it. So we might have sponsored conversations. So companies may pay for a conversation about something, and it would enable specific tracking to be applied to those conversations that are surround it, and then allow research to be made or drawn from it. We'll have sponsored pages, so there'll be advocated pages, so we might have specific celebrity type people in the healthcare industry, or figureheads should I say, advocating a topic in order to spark that conversation. People will be able to subscribe to a digested version of the topics, so every day they might be interested in depression, they could find the latest trends in depression conversations. It could enable charities to find match funding with actual authorities or maybe drug companies or whatever, in order to find out more information about their specific interests without having to find all the funds themselves. It'll give community intelligence. Because all our social media is tracked with geocodes, we can collaborate that information to specific groups if we need to, rather than just having a worldwide conversation about it. So if people are talking about depression, well, what specifically people are talking about depression in York? Is there something about York that raises more reason for that sort of topic of discussion? Because of the identification of these health trends, it will allow people to realise areas of the health industry that need more further conversation, whether it be higher up through the public sector or local community areas, because that's the topics that are important to the people that are discussing them on social media. Gaps in provision?
Yeah.
I don't know that one.
It's like health pressure points in...
Yeah, okay, so it's going to identify these pressure points. And then it can be used for specific research topics for academics or the universities alike to follow up.
That's it, but we've got the interfaces down
But yeah, we have a rough interface, so one part of the interface will start discussing it with topic first. So you'll pick your area of interest and you'll follow that thread into a collection of all the conversations related to, say, for example, children or the elderly or health. Then you could also focus on your local area, and will identify the trending topics and the trending conversations that are important. Some of them may be sponsored, for example, Bupa may be doing a big push on elderly care, and anything discussed with elderly could be sponsored by Bupa in order to fund the operation. but it would act like a very dynamic and very real-time infographic about the health issues in a specific area or for a specific piece of information, sort of with visual graphs and identify, and sort of community groups can be identified to bring people together, so specific topics are allowed people to collaborate on in this public space. But the idea is to bring the world's voice, to encourage them to talk about the health, talk about these issues, that have a conversation with people that are important, raise these points that may be just kept under the rug or not discussed into a single centralised location, so that
And spark action.
and spark the community action. Yeah. Done.
Excellent. Thank you
Well done.
very much.
Box of Delights and revealing our title, and here it is, we'll hold it between us. So we want to develop a toolkit of using the digital and performing arts to help involve the disconnected patients in decision making and treatment options. So we'll just elaborate a bit on that. It's informed to some degree by some existing research about using performance and digital arts and digital performance to facilitate what we call requirements elicitation, finding out more about how something should be designed by asking people, involving people, getting a visceral response, using role play, all those kind of things. But perhaps we should explain, what do we mean by a toolkit? Do you want to cover that?
Right, so looking at this, it's really just a filter in and a filter out. So we're talking about people who are disconnected through their own choices. So at one level, we wish to engage. If they want to take part, then they become involved. The toolkit gives them resources, and we use the toolkit so that they can then perform in whichever way of performance art or music that they wish. That experience is then used to derive a learning experience about empowerment, about how they can control their life, how they can therefore control their own treatment and talk more with their professional help. The other thing at the end of this is we share it. The experience is shared, it returns to the box. The box then becomes larger and becomes more to involve more people in more ways.
Why don't you just explain a bit more about the disconnect, what we meant? We were struggling for the words.
We've come up with a term which is disconnected people, and I was one of those. Mental health, I became very insular, never went out, didn't speak to anyone, wasn't communicated with. So that is one of the disconnected. But we also have people who are disconnected through geography. Their illness may actually mean they can't see other people. And there are even some specifics with people who don't even have the ability to speak, and they're disconnected as well. But we don't want to label anyone with it, we just want to stick with disconnected. We've given some examples that stick with disconnected, could be anybody.
So this is the project. So connecting the disconnected through the box of delight. So to enable people to control their treatment and their lives. So you've got two parts. You're saying, do you want to open the box? It's an open invitation to people if they want to be involved in taking control of their lives. There's a second part, what would you put in it? By doing what you do, by creating something yourself, not merely do you create a life experience which you learn from, you actually can enable the lives of other people in the future. Yeah. So it's a three-part invitation. It's, for some people, do you wish to open it? Some people won't. That is a choice, and that choice is something that we have to be able to open to in a personalised and patient-led industry. Secondly, an invitation to use it. Even once opening it, you can take a choice of you don't want to be part of it. But then for some people, they do. They will want to perform. They will want to be part of this system. And they will possibly then want